So as we go on to the objective examination, we'll keep with hip for an example here. If I'm going to be looking at the back, one of the first things I like to do is a myotome exam. I find myotomes are the most sensitive. I don't have real good research on that. And the reason is because when we look at research, a lot of times those subjects, there's an MRI or EMG gold standard. They're about to go in for surgery and they're testing these things. What is that? I mean, that's most of our patients in a physical therapy clinic are not about to go into surgery. They're hoping that we can help them. And so I often find that good myotome testing is the most sensitive, and I'm pretty rigorous with it. If I find that there's ankle or toe weakness, for instance, you think about ankle dorsiflexion or first toe extension, those are good L4, L5 tests. If that's weak, that really helps me build a case. Your hip isn't making your foot weak, but your back may be, and it starts building that. Now, could their hip pain be from the back and not have any of the myotomal weakness? Sure, but if we get that, then it's an easier build. So it's a little bit easier sell later. So I typically will do that early on, because if it's a lot weaker than I would anticipate, sometimes it's a little weak, but if it's really weak, maybe there's more pathology going on and I need to be more careful in my exam. So there's different ways to structure an exam. My standard is to go neuro first. And then if I have to get them back up, I'll get them back up and do some more functional testing, repeated motions and whatnot. And so baseline is neuro. I get them up. And that's what I want to see. What do lumbar motions look like? I want to look and see what they look like to me and what do they feel like for the patient. And I know, avid listeners of your podcast are going to be pretty familiar with MDT approach, looking at repeated motions. And that's essential. And it catches most of them, but I do have one example of a lady that it missed recently. She came in with coccyx pain, and pain was sitting. Seems like pretty classic coccyx pain. It was tender to the touch at the coccyx, and I did a lot of my normal coccyx treatment, and it wasn't better after 2 or 3 visits. And normally I see some improvements. I really hadn't seen any. And the first day I said, well, I don't think it's your back. She didn't report any back pain, but let me clear. I had her do some repeated motions. I even had her do lumbosacral extension combined with a standing extension 10 times. I did a quadrant when I overpressured it for 10 seconds on each side. And I was like, okay, I'm confident, we don't need to look at your back anymore. But when we hadn't made progress, I say, okay, what have I missed? And when I went, I did some palpation assessment. I saw it was very sensitive to touch her back. And when I treated the back, we instantly started making progress.